This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2019, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is 6 milliliters per kilogram tidal volume is not appropriate for all patients. Dr. Neal Thomas is Professor of Pediatrics and Public Health Sciences, Division of Pediatric Critical Care Medicine, and Associate Dean for Clinical Research at the Penn State College of Medicine in Hershey, Pennsylvania. He also serves as Vice Chair of the Pediatric Acute Lung Injury and Sepsis Investigators, the Polisi Network. Dr. Thomas discloses he has relationships with Therabron, CareFusion, and Gene Fluidics.
So I'm Neal Thomas from Penn State Children's Hospital and Penn State University College of Medicine. I'd like to talk about why 6 cc's per kilo of tidal volume may not be appropriate for all patients. The objectives that I would like to cover in this presentation today are, first of all, to review the present literature related to tidal volume in adults with ARDS. Secondly, to describe the literature in pediatrics related to tidal volume. And finally, to determine the next steps for research into appropriate tidal volumes for children with pediatric ARDS. And I'd like to start with a case. The case is a 12-year-old child who we've all seen in our pediatric intensive care units with influenza B, who develops tachypnea, increased work of breathing, and is taken to the emergency room when he gets worsened. Oxygen saturations are 88% on room air, and his chest x-ray looks like this. After this child fails non-invasive mechanical ventilation, he is moved to the pediatric ICU and intubated. And I would like the audience to consider what tidal volumes they would use for this patient. Would they use less than 6 cc's per kilo, between 6 to 8 cc's per kilo, 8 to 10, or greater than 10 cc's per kilo? And what I'd like to do is have that decision based on the pediatric knowledge, not the adult knowledge. Because we know that in 2000, the Adult ARDS Network published the AROMA trial, which compared tidal volumes of 6 cc's per kilo and 12 cc's per kilo in adults with ARDS. And with a standardized ventilation algorithm and a PEEP FiO2 grid, what they found was a remarkable difference in outcome. They had an absolute 9% reduction risk in outcome and an increase in ventilator-free days. So this clearly set the stage for ventilation practices to change in the adult population. If that was the answer, then we would be ready to go home, and it would be Miller time. But unfortunately, as my friend Lee Corso says, not so fast, my friend. There was a lot of controversy about this study that started immediately after it was published. Some of the groups you can see here, and there were many more, that basically made the case that 6 cc's per kilo of tidal volume was not better, but it was just better than 12, and that the control group, which received 12 cc's per kilo, was harmed by this intervention. Taking the adult AROMA study at face value, I think we can clearly say that 6 cc's per kilo is better than 12 cc's per kilo, but I don't think we can say any of these other options. We don't know if 6 is greater than 8 or 9 or 10 because the study did not address that. As with most studies in medicine, once there were a few randomized controlled trials, authors take meta-analysis into effect, and this is the first meta-analysis that was done by Putinson. And what they found was that based on the limited number of RCTs, that it appeared that lower tidal volumes were better. However, the AROMA trial, which was the one large trial that was included in this meta-analysis, really drove the results of this study. The NIH critical care group, which was also critical of the AROMA trial, did their own meta-analysis, and how they broke it down was an interesting way where they used two different forms of studies. They used the study that compared 7 cc's per kilo versus 10 and 6 cc's per kilo versus 12 cc's per kilo. And as you can see with the studies represented on the right, there was a clear benefit that 6 was better than 12. But in the studies that looked at 7 versus 10, which are demonstrated on the left, they were non-beneficial and maybe even a signal of potential harm with the lower tidal volume in this adult patient population. And so they made it very clear that this meta-analysis demonstrates there are significant differences in the control arm that can account for these discrepant results in these trials. So this was all based in adults, and there was really nothing that was based in children at the time. So what do we do in the pediatric ICU? Well, unfortunately, we are like lemmings and we follow what our adult colleagues tell us to do. So 6 cc's per kilo must be correct. And what I'd like to do is go through the literature of what is available in pediatrics to show you that we may not want to jump off this cliff. To begin to understand the question about differences between adults and children related to ventilator-induced lung injury, we will start with the animal studies that have been conducted to address this question. The first study was performed by Brian Kavanagh and his group at Toronto Sick Kids, published in the American Journal of Respiratory and Critical Care Medicine. What that group did was they ventilated neonatal and adult animals with higher tidal volumes, and they measured the amount of inflammation that occurred related to these tidal volumes. As you can see in the top graph, IL-6 level was higher in adults ventilated with 25 cc's per kilo of tidal volume, as opposed to newborns with 25 or even 40 cc's of tidal volume. Now, these tidal volumes may seem large compared to what we use in children and in adults. However, the physiologic variables that are different between animals and humans make these clinically relevant. In the bottom graph, tumor necrosis factor alpha also is much higher in the adults that are ventilated with higher tidal volumes as compared to the newborns with either 25 or 40 cc's of tidal volume. The next study that this same group did, that was published also in American Journal of Respiratory and Critical Care Medicine, looked at lung development and susceptibility to ventilator-induced lung injury specifically. What can be seen in the graph on the left is that the hyaline membrane score, which was used as a marker, an outcome marker related to lung disease that occurred with large tidal volumes over a period of time. The groups that they studied were infant animals, juvenile animals, and adult animals. And what can clearly be seen is that there is a large difference between the adults and both the infants and the juveniles related to the hyaline membrane score when they were ventilated with large tidal volumes. In the graph on the right, the inflammatory markers in the bronchoalveolar lavage fluid in these same animal populations show differences between newborns and adults ventilated with high tidal volumes, again signifying that adults appear to be more susceptible to ventilator-induced lung injury. At least adult animals appear to be more susceptible than pediatric animals. There's a review article that was written by Lincoln Smith from Seattle Children, which really dives into details about the mechanisms of ventilator-induced lung injury in children and why children are different from adults in terms of their susceptibility. I highly recommend that this be required reading for anyone who's interested in discussing and understanding the role of tidal volume in ventilator-induced lung injury, and also interested in future research that aims to answer this question. So, what about interventional trials in pediatrics? I showed you some adult interventional trials. I've showed you some animal models. What do we know about interventional trials in pediatrics? Unfortunately, we have nothing. There is not a single interventional trial in pediatrics that can answer this question. And so what we have is many discussions about whether we could proceed with a randomized controlled trial in this patient population. In our research network, the Pediatric Acute Lung Injury and Sepsis Investigators Network, we've talked about this for many years, but most people feel that we could not complete this. And so what is the present literature specific to children, we really are limited to observational studies. I'll start in 2005. Heidi Flory from Children's of Oakland developed the first large data set of pediatric acute lung injury patients using the American European consensus criteria definitions. And her patient population was 328 children with acute lung injury or ARDS. Mean tidal volume was 10 cc's per kilo. So this was about the time that the AROMA trial was out and recommended 6 cc's per kilo, where the tidal volume in this patient population was actually much higher than that. The population has good face validity in that hypoxemia was worse in the patients who did worse. And these are the outcome variables of the univariate analysis, and what I'd like to do is blow up the exhaled tidal volume to show that there was no association between tidal volume and mortality, and no association between tidal volume and ventilator-free days in this patient population. So this was the first signal in pediatrics that tidal volume may not be as important as it is in our adult colleagues, at least in this one study with a relatively moderate tidal volume. In the Indian Journal of Critical Care Medicine around the same time, there was a study that looked at the effect of lower tidal volume versus conventional tidal volume in outcomes in children with ARDS. It was a prospective database collection with retrospective controls, which ends up being one of the significant weaknesses of this study. There were 153 children total with ARDS. And when you read the manuscript, you can see that there's a mortality of 23% versus 36% in the two groups. They titled the groups 6 to 8 cc's per kilo and 10 to 12 cc's per kilo. And you could see that the mortality was lower in their what is titled lower tidal volume group, and the duration of ventilation is shorter. The problem is that there was no true control group, and the only thing they did was they changed their practice to aim for 6 to 8 cc's per kilo in the later cohort, as opposed to aiming for 10 to 12 cc's per kilo in the higher cohort. In fact, when you read the publication, tidal volumes aren't actually reported. So they're just reported as these two groups in what their target was. And we know that what physicians say their target is not always what they achieve. Brian Kavanaugh's group moved from the bench to the bedside and looked at whether ventilation practices that have changed improved outcome in children with acute lung injury. This was a retrospective study, again, using historical controls. This was defined by time, and the time epochs were further apart than the previous study that we just discussed. 1998 to 1992 versus 2000 to 2004, with 164 total children with ARDS. The tidal volume was higher in the older group, so 10 cc's per kilo versus 8 cc's per kilo, and these were reported tidal volumes, not what they targeted. And what they did find was that the newer group had a lower mortality than the older group, and that was significantly different. And they also had significantly more ventilator-free days. So it seemed that the children in the later cohort, 2000 to 2004, had better outcomes than children from 1988 to 1992, and they had lower tidal volumes. The thing we can't judge is causality as opposed to just simple association. So this is their survival analysis, and the recent group had more survival than the older cohort. And when they looked at the oxygenation index the tidal volume in epochs from less than 6 cc's per kilo to greater than 12, you can clearly see that the higher tidal volume patients had a higher mortality, despite having similar oxygenation index and similar risk of mortality with a PRISM score. Again, these were encouraging results, but the overall mortality may just be improvements over time. And to demonstrate that, these are data that were put together by Scott Watson as part of our PELIC group. And Scott took all the pediatric ARDS studies and looked at mortality over time, independent of what the studies were based on or what their intervention was or if they were observational. And you can clearly see that there was an improvement in mortality over time. And so it may be that these data are just a representation of improvement over time and not related to the tidal volume. The nature of the study leaves this question unanswered. Simon Erickson and the Australia-New Zealand critical care group performed a very strong study that was published in 2007, a prospective multi-center observational study of 117 children with acute lung injury and a 35% overall mortality, which is consistent with what other populations have demonstrated. What Simon found was when he looked at ventilator variables and the relationship to mortality, things like higher PEEP and higher mean airway pressure were associated with worse outcome. But when he looked at either the maximum tidal volume or the median tidal volume over the course of 3 days, what he found was that higher tidal volumes actually seemed to be protective, and that the higher tidal volume groups did better than the lower tidal volume groups. This caused a lot of concern because the data were really flying in the face of conventional wisdom. And Simon was very careful that when he went to correct it for severity of lung disease, still there was reduced mortality with the median and mean tidal volumes, and so higher tidal volumes are better. And again, Simon was very cautious and said it would be wrong to conclude that a lower tidal volume strategy would not be effective, and a randomized control trial would answer that question. Halberdson in 2009 looked at the question in a different way. He broke his patients down into 3 groups: less than 9 cc's per kilo, 9 to 12 cc's per kilo, and greater than 12 cc's per kilo in a retrospective fashion. And the admission characteristics between the groups were actually demonstrated that they did have separation between the 3 groups. You can see that there is a tidal volume of 8, 10, and 14 cc's per kilo in the 3 groups. And really not much of a difference in risk of mortality based on PRISM or PIM scores. There also wasn't a difference in mortality, and so despite these 3 different tidal volume groups, the tidal volume was the same and maybe a hint toward lower mortality in the group that had the higher tidal volume of 14 cc's per kilo, again flying in the face of conventional wisdom. So Robbie Kameni from Children's of LA in 2009 published in Intensive Care Medicine his cohort of 398 patients with acute lung injury, overall 20% mortality in this retrospective study. 70% of the children in Robbie's study were ventilated with tidal volumes between 6 and 10 cc's per kilo, which in the mid-2000s was contemporary in what people were using across the country. What Robbie found was that the median tidal volume was not significantly different between survivors and non-survivors in this large cohort of patients. There was also a non-significant trend toward improved survival in children who were ventilated with higher tidal volumes. And his data are presented here in these 4 graphs: initial tidal volume, day 1 tidal volume, day 2 tidal volume, and day 3 tidal volume. What you can clearly see is that there's a trend toward a lower mortality in the patients who were ventilated with higher tidal volumes. Again, a non-significant trend, but still an overall trend that was consistent across all 4 days. When Robbie tried to make sure that it was representative of the entire population, he broke down his cohort into patients with a higher lung injury score and a lower lung injury score, and again found the same non-significant trend toward lower mortality associated with higher tidal volumes. Not causal, but association. The Chinese Collaborative Study Group for Pediatric Respiratory Failure conducted 2 studies in 2010 and 2012. The first one is presented here, and this was a prospective observational multi-center study of 306 children with ARDS and a mean tidal volume of 8.8 cc's per kilo. The overall mortality was higher, 45%, and it makes it a little bit difficult to compare the results of this study to the previous studies. But what this group found was no significant difference in tidal volume between survivors and non-survivors. They did see some non-significant trends. The mortality was 39% with a tidal volume of less than 8 cc's per kilo and 47% in those with greater than 8 cc's per kilo, but this was non-significant. They followed up this study with a larger study, again, the Chinese Collaborative Study Group for Pediatric Hypoxemic Respiratory Failure. And this study was published in 2012, a prospective observational multi-center study of 439 children with acute hypoxemic respiratory failure. The tidal volume was a little lower at 7.7 cc's per kilo, and the overall mortality was lower, but this was a less sick patient population because it was acute hypoxemic respiratory failure compared to the previous study, which was ARDS. When they conducted their logistic regression of variables that associated with mortality, you can see them listed there. The thing that's important is that tidal volume was not at all associated with mortality. When they looked at their Association over the first 7 days, they saw absolutely zero association between tidal volume and the first 7 days of mortality. And then when they broke down the groups into less than 6, 6 to 8, 8 to 10, and greater than 10 cc's per kilo in mortality, again, no association was found. When they looked at their secondary outcome, which was ventilator-free days of less than 14, the interesting factor was that a lower tidal volume seemed to be harmful, and that patients with the lower tidal volume had less ventilator-free days, signifying that they required mechanical ventilation longer if they received lower tidal volumes. Again, an interesting finding for an observational study. They found no association between the tidal volumes, again in their groups of 6, 6 to 8, 8 to 10, and greater than 10, and duration of mechanical ventilation in the first 3 days. So just like the data that was presented with the adults and a meta-analysis, a pediatric meta-analysis was also performed by Martin Niebuhr and colleagues and published in Critical Care Medicine in 2014. What Martin did was a systematic review and a meta-analysis of all the observational studies. Really, the objective was clear. It was to determine whether tidal volume is associated with mortality in critically ill, mechanically ventilated children, with and without ARDS, and I'll demonstrate some of those data shortly. They started with a large number of publications and with removals and determining whether publications were eligible. They ended up with 8 total publications that were included in their meta-analysis. If you look at the list of publications, you'll see that many of them are the ones that of results that were already discussed in this presentation. To orient you to this slide, with a meta-analysis, the middle bar is the determination that there is no difference between groups. And the large diamond at the bottom of each of those figures determines, will let the reviewer know whether a potential therapy is beneficial or harmful. If the therapy is to the left of the bar, it is beneficial. If it is to the right of the bar, it is harmful. And as can be seen in Figure A, where the patient populations were divided into tidal volumes of less than 7 cc's per kilo or more than 7 cc's per kilo, the studies had some variability around that center line individually. However, together, there is absolutely no difference in association between tidal volume and mortality. In Figure B, the same type of analysis was conducted. However, the tidal volume that was used was 8 cc's per kilo, so greater than or less than 8 cc's per kilo. And again, no difference, no benefit, no harm related to tidal volume. In Figure C, 10 cc's per kilo was the cutoff. And again, you can see that while the individual studies may vary, overall there is no difference, there is no benefit, or there is no harm. Finally, in Figure D, 12 cc's per kilo as a cutoff for greater than or less than. And again, you could see a lot more variability because of smaller patient samples in this group. However, the main diamond shows that there is absolutely no association between tidal volume and outcome. Martin's group went further and determined broader aspects of variability between their groups. And so the data represented in Figure E was a tidal volume of less than 7 cc's per kilo and a tidal volume of greater than 10 cc's per kilo. Again, some individual variability in the studies, but overall there was no difference in outcome. They furthered that in Figure F by tidal volumes of less than 7 cc's per kilo and more than 12 cc's per kilo, and it demonstrated no difference in outcome. In G, the cutoffs were less than 8 cc's per kilo and greater than 10 cc's per kilo, no difference in outcome. And in Figure H, less than 8 cc's per kilo and greater than 12 cc's per kilo. And again, consistently no difference in outcome. When you look specifically at the children with acute lung injury or ARDS, so those with a PDF ratio of less than 300 or less than 200, with the same cutoffs of greater than or less than 7 cc's per kilo, greater than or less than 8 cc's per kilo, greater than or less than 10 cc's per kilo, or greater than or less than 12 cc's per kilo, no difference in outcome related to tidal volume. With these broader gaps of less than 7 and greater than 10 cc's per kilo, less than 7 and greater than 12 cc's per kilo, less than 8 and greater than 10 cc's per kilo, or less than 8 and greater than 12 cc's per kilo. Again, a very consistent signal of no association between tidal volume and outcome. So that meta-analysis was done in 2014. What's been done since then? Well, unfortunately, there hasn't been a lot done in this field, and I'd like to talk about whether we could generate some more data as we move forward. So a study that was published in 2015, a completely different patient population that looked at tidal volumes in pediatric burn patients with inhalational injury. And the tidal volumes here are a lot different than most of what I've showed you so far. Their low tidal volume group was 9 cc's per kilo, and their high tidal volume group was 14 cc's per kilo. Again, in this patient population, which stretched all the way back to from 1986 to 2014 in a large patient population. What they found was that they had, in their lower tidal volume group, they had more ventilator days, so the patients required their ventilator longer. They had more atelectasis, and they had more what they defined as ARDS in this patient population. So the higher tidal volume group appeared to do better based on the outcomes that they defined in this retrospective look. They saw no difference in outcome, and this is not surprising because pediatric burn patients generally will not die from their lung injury. And so seeing a difference in mortality would be very surprising based on this analysis. Nader from CHOP and I looked at the CHOP database trying to look at lung mechanics and oxygenation in pediatric ARDS. And this was not the focus of this study, but I will draw your attention to figure C, which looks at tidal volume both at ARDS onset and at 24 hours. And what we found in this large patient population was that there is no difference in tidal volume between survivors and non-survivors, either at PARDS onset or at 24 hours. David Imber, who's a medical student at CHOP, looked at tidal volumes adjusted for ideal body weight, and this is a publication that is in press in pediatric critical care. The first thing we found is that we're not really clear when we set our tidal volumes what body weight we're using. And actual body weight versus two different measures of ideal body weight, there's a significant difference in tidal volume. So we are ventilating children if we're using actual body weight with higher tidal volumes than we think we are, both at PARDS onset and at 24 hours. And this is another way to represent this, that you can see that the graph has shifted to the right in that we are actually using higher tidal volumes than we think we are. However, based on whether we use actual body weight, ideal body weight, by the two different methods, there is no difference between survivors and non-survivors at PARDS onset and at 24 hours. We saw no significant signal that tidal volume impacted outcome in these children. Again, completely different patient population than the ones I demonstrated before. And that is really all of the pediatric data. We really don't have much more, and most of what I showed today was observational data, and that's what we have. So what's done in the pediatric ICU? What do we do presently? Well, this was a study that our network published in 2010, which looked at an international view of what people do in pediatric ARDS. It was called the PALIVE study, and what we did was we measured patients over many centers. The mean measured expired tidal volume was 8 cc's per kilo of actual body weight, and here you can see that the range was highly variable, and this is pretty consistent even with contemporary data. So even a decade after the AROMA trial, pediatricians were still ventilating well above the 6 cc's per kilo that was recommended in adults. We followed that study up with one that actually asked providers what they did. So we know what they did. Then we gave them 3 scenarios of pediatric ARDS and asked them to tell us what tidal volumes they would choose for their patients. And the objective really was to determine what people say they do is different from what they do. This was the same patients, the same centers that participated in the observational trial were now answering the questions. And what you can see is that the majority of pediatric intensivists said that they would generate anywhere between 5 and 8 cc's per kilo of tidal volume, with very few being up to 9 to 10 cc's per kilo. However, when you overlay the data from what they actually do, you can clearly see that even though everyone says they generate lower tidal volumes when they ventilate, they clearly use higher tidal volumes in these patient populations. So what we say we do and what we do are two different things, and I think that is an important lesson as we move forward. So what's done in the pediatric ICU now? Well, this was a study that was done by Sean Ward, where she looked at data sets from randomized controlled trials that we conducted through our Pediatric Acute Lung Injury and Sepsis Investigators Network, our PLESI network. These were trials where patients had suggested algorithms for ventilation that included low tidal volume. And what she found that the median tidal volume was 7 cc's per kilo, lower mortality, but because of the randomized controlled trials, certain patient populations with higher mortality are excluded in this 315 patients. What she found was that only 30% of patients were ventilated less than 60.5 cc's per kilo, and up to 40% were ventilated with greater than 8 cc's per kilo. So even in a randomized controlled trial where pediatricians are given parameters to ventilate, we still don't follow low tidal volume ventilation. I won't say whether that's a good thing or a bad thing, but these are just the facts as presented in this paper. When Sean looked at whether pediatricians changed their practice over time, before 2006 and after 2006, for those who used more or less than 6 cc's per kilo, there was no difference in time. However, with the 8 cc's per kilo, what she found was that pediatricians actually are using higher tidal volumes now after 2006 than they were before 2006 in these randomized controlled trials. So there was a lot of people jumping on the bandwagon and using low tidal volumes early in the course after the adult ARMA trial, and people seem like they are starting to get away from it years after the ARMA trial. So in an attempt to address this question internationally, we recently conducted the Pediatric Acute Respiratory Distress Syndrome Incidence and Epidemiology, or PARDI study, which was an international observational study of over 700 children with pediatric ARDS around the world. The study was published in Lancet Respiratory Medicine. The study was conducted across 202 sites in 33 countries and 6 continents, and what it included was data analysis over the 7 days of pediatric ARDS across patients that were treated in pediatric ICUs around the world. The idea was to get a true incidence and epidemiology of pediatric ARDS, but also to conduct further sub-studies in what is listed here. We wanted to understand the risk factors for mortality in pediatric ARDS, and one of these risk factors includes tidal volume. We will have data available that will help us understand whether tidal volume is associated with mortality around the world. The V2, which was the monitoring and ventilator management in pediatric ARDS, will have detailed every 6-hour ventilator management of patients with pediatric ARDS, and we will be able to determine tidal volume in these patients over the course of time and determine if there was an impact of tidal volume. These data are presently being analyzed and will be available, but for now, all I can say is we all need to stay tuned and we will find out the answer together. So I started with saying that pediatricians are lemmings and that we follow our adult and sometimes neonatal colleagues off the cliff in terms of treatment of patients with lung injury. Maybe we really aren't. Maybe we have enough observational data that says we need to answer this question for ourselves. And what is the answer? Does tidal volume influence outcome in children with pediatric ARDS? Should we use the adult ARDS data and simply extrapolate it to children? I think it's pretty unclear right now, and the more you read the literature, the more likely you are to be confused about what happens in children with pediatric ARDS. The presentation started with asking the audience to determine, based on the available pediatric literature, in a child with pediatric ARDS, what tidal volume would be used. I'd like everyone to think back now and see if their answer has changed. Did their answer stay the same in that they would use less than 6 cc's per kilo, or would they use higher tidal volumes based on the literature that was presented? So how do we answer this question? How do we get to the final answer to say what is the appropriate tidal volume? Is lower tidal volume ventilation appropriate for children? What is the next step? Well, I think the next step needs to be a randomized controlled trial. This is something that we've discussed in detail for many years in our Pediatric Acute Lung Injury and Sepsis Investigators Network. And Martin Neiber and Peter Remsminger conducted a survey among pediatric intensivists based in Europe about the need and feasibility for a pediatric ventilation trial aimed at answering the tidal volume question. What their conclusion was that expert opinion greatly favored investigating the effect of 6 cc's per kilo versus 10 cc's per kilo in mortality. That appeared to be the sweet spot that most people thought should be studied. However, studying this would be incredibly difficult. There is a lack of equipoise about tidal volume in the pediatric population, and so it would be incredibly difficult, if not unrealistic, study to conduct. However, the author suggested that further observational studies might be necessary before embarking on this randomized control trial. And as I mentioned, the party study may be that observational trial that gets us to that next step. So based on adult literature, it is fairly clear that low tidal volume ventilation does decrease mortality in ARDS patients. However, based on the pediatric literature, this is completely unclear. Does low tidal volume ventilation impact outcome? Is lower tidal volume ventilation better for children? Or does the pediatric literature support higher tidal volume ventilation in children in that they may not be as susceptible to ventilator-induced lung injury? The question is unanswered at this point. Thank you.